chief complaints of swelling in the below the right ear, and that has gradually increased in size over 2 years. The swelling is non-tender. It is not associated with there is no history of fever. There is no history of fever chills. There is no history of cough. There is no history of weight loss. There is no history of decreased appetite. There is no history of similar swelling in the other parts of the body. In the past history is unremarkable. In general examination,
what other history you would like to take? Any
there is no history of trauma. There is no
any history of tuberculosis?
yes, sir. There is no history of cough, evening rise of temperature.
कभी कुछ टीबी का इलाज तो नहीं चला आपका पहले? टीबी की कोई शिकायत किसी को घर में? टीबी की बीमारी किसी को घर में? Okay.
No history of cough.
Fine. So examination.
So on general
Nothing else?
examination,
History of drooling of saliva.
there is no
History of loss of weight. Basically trying to find out history which is relevant to the swelling, and history which is relevant to the effects it can cause to the surrounding structures, like facial.
there is no history of deviation of the.
There is no history of drooling of saliva. This is what happens normally. Okay. There is no history of any facial weakness. It will all be relevant in this case. No history of fever. No history of weight loss. No history of body aches or basically metastatic examination.
In general examination,
Yes.
So do we need to mention pain during mastication?
Any pain during
there is no
mastication?
pain during
Is that
mastication.
important? If there is mastitic involved. Particularly we are trying, what are we trying? We are thinking about a swelling in the region of the parotid, which could be inflammatory, non-inflammatory, that is malignant, or inflammatory, or non-specific. Inflammatory would have features of local inflammation, systemic features of inflammation. Malignancy would have local features of malignancy and systemic features of malignancy. These are the histories you have to take, examination.
History of fever to months.
That's why I said inflammatory, it's included, so let's not dwell into further. Inflammatory features would be history of, local features would be pain, difficulty during mastication, or you have features of mastitis. Importantly, any increase or fluctuation in the size of the swelling during chewing or mastication.
There is no change in size of the.
That's obviously not a very common sight for stones. Carotid duct is less common than submandibular duct. You know why?
Submandibular duct is more
The secretion of carotid are more liquid. Those of submandibular duct, the submandibular are more viscous. Then the duct, submandibular duct has to go against the gravity. Carotid duct has to come with the gravity. So it drains well, that drains against the gravity. And then in the Wharton's duct towards its termination, there is a hooking by the lingual nerve, so which makes it another reason for obstruction. Clear to all of you? Right, should be? So that history will therefore become important. So history basically you are trying to take the local disease in mind and the systemic. Okay. Examination.
In general examination, she is average built, well nourished girl with she is having the not having pallor, not having
Anything in the general examination which is significant?
So I should look for lymphadenopathy.
Is there anything else?
There is
Local lymphadenopathy or
Local
regional
lymphadenopathy,
right?
there is-
Subsequently. Okay.
no pallor, no clubbing.
Okay, let's come to the local examination.
On inspection.
Once again, do the same thing. Go in front of the patient and come eyeball to eyeball. You can actually see that there is, there's a little fullness on the right side under the ear. Left side, when you compare it, and you can make out that it's fullness. You look at the facial symmetry again. We should discuss everything. Everything else, there's no visible deformity of the face that you can see. Then you get on with the swelling. Okay.
On inspection, there is a single oval in shape swelling below the right ear, which is 3 by 4 centimeter in size. Skin overline swelling is normal. There are no scars, sinuses, or ulcers. Facial symmetry is normal. There is
Discuss that already.
no obvious swelling in the other head neck region on palpation. The swelling, there is single oval, non-tender, swelling of size 4 by 5 centimeter, which is skin overline swelling.
You say there is a swelling in the parotid region. What are the boundaries of the parotid region? The boundaries of the parotid region are, if you draw a straight line from the zygomatic process midpoint, draw a straight line.
Yes.
Draw the next line from the angle of the mouth, angle of the mandible. And the third one from the mastoid process. This is called mastoid, this is called parotid region. And any swelling arising in the region, in this region, is taken as parotid unless proved otherwise. Very often you can find parotid lymph nodes can get enlarged, but they will still call it a parotid swelling. Don't be too much fussy about the lifting of the ear lobule. it may or may not be lifted. Okay, so don't be too bothered. We look for the facial symmetry and weakness or the deformity of the face to test for facial. Fine. Now that's the swelling. Okay.
Skin over the swelling is pinchable. Swelling is non-tender. Swelling is not fixed to deeper
Local
surface.
temperature is not less,
Local
skin is
temperature is
pinchable,
not
it's non-tender swelling.
Yes. Swelling moves in vertical and horizontal.
It's a mobile swelling.
Mobile swelling. It is non-tender. It is firm in consistency. Intraorally, the swelling is not palpable. Skin overline swelling is normal. There is no other swelling in the other side of the face.
Okay, so we talk about palpation. We've done inspection, we look at the skin color, change, the visible signs of inflammation basically. Any local sinuses, scars, erythema, rightly brought up. Then you look on palpation, you look for tenderness, local range of temperature. Basically inflammatory signs again. Consistency, firm, not hard, mobile, not fixed. It's mobile.
Yes,
It's not fixed. Yes, and you can see that the swelling is getting over the mandible, which also is a feature of carotid swelling rather than a lymph node. Lymph node would not get above the mandible. Why? Because the deep fascia gets inserted on the mandible while it splits into two and encloses the carotid. So if anything gets over the mandible, it's not a lymph node. Very unusual. Then,
cervical lymph nodes are.
no, we are not finished with this. Now there is no tenderness, and then you go to examine the carotid duct inside as well as outside. You look for the opening, we have seen that. Where do you look for it? Follow torch.
It is on the lateral.
We got a real cooperative. Normally used to be wearing, you ought to be wearing gloves. You can zoom now if you want. How do you retract this? So don't do that. So you retract it with a glove finger. Opposite the second molar. You've seen that yesterday, so there's no problem. And you'll also palpate it outside. How do you do that?
On the behind of patient.
Okay. Carry on here from here only. You can turn the patient around. Shabash. Then put them up. Okay, there were gloves. You will always examine the neck from behind in that situation. You look at the lymph nodes and adjust the feeling, and you can feel that there are a couple of lymph nodes here. Okay, I've seen the way so that your attention is okay. It is just started. When you look into the oral cavity, you at the same time look for you don't palpate for the deep lobe, you actually inspect for the deep lobe. Don't try to do bimanual palpation in all the cases. It's a wrong statement. I did the previous match. You will look for the displacement of tonsillar pillar. Then only you look for bimanual palpation. You don't do in all the cases. It's very difficult. It's problematic for the patient. It causes gag. The patient starts finding it difficult. So you don't do bimanual palpation routinely. Unless the pillar is deviated, don't do that. Okay? No bulge felt seen inside. Done. Okay? Then?
There are no cervical lymph node enlargement. No palpation. I could not palpation.
Okay. Now you can move. You can move here, I'll show you. To examine from behind, just flex the neck and you look for the lymph nodes. I'll make you feel this now. Bring your fingers. None of you put out. Bring your fingers on my fingers. Small lymph nodes. What size?
0.5 to 1 centimeter.
0.5 to 1 centimeter. What's the normal significant size of lymph nodes?
1 centimeter or more. Just the right to 5 minus 2 centimeters.
Let's talk about the right. And they're free, they're not matted, mobile, non-tender. They're felt on the left side also. That's it. There are lymph nodes. You want to feel?
But less than 1 centimeter. So
No, but lymph nodes are palpable. You won't say they are palpable. It's
Yeah.
okay. The lymph node is palpable, it's palpable. Whether this in the presence of, suppose this comes out to be malignancy, then it's a significant. Okay, you can examine later. Patient would be here. Fine. Now the cervical lymphadenopathy is present. Okay, after that you look for the facial nerve. You can easily say the examination of the facial nerve is normal. I don't need to demonstrate or ask you. How do you look for it?
So there is no,
How do you
ask
look
the
for
patient to look the cheek,
ना दिखाई
show the clean
ऐसे करके दिखा पूरा मुंह खोलो ऐसे दो देवेश मुंह खुलाओ जरा ऐसे खुलाओ घबराओ नहीं कुछ नहीं okay
is not emission.
so we have a case of carotid swelling on the right side which is firm in consistency
Non-tender.
non-tender with no facial involvement any swelling arising in the region of parotid region is parotid region. It's taken as parotid unless proved otherwise. Don't get confused over it. If there's a lymph node felt along with it, you better find out the reasons for the lymphadenopathy. Don't try to explain this as a lymph node. It can't be. And don't argue on things like it could be arising from the tail. There could be a parotid group of lymph nodes. There are parotid group of lymph nodes, but they can't be fed separately from parotid swelling. Is that clear? Now, so what's your diagnosis?
Pleomorphic and mixed parotid tumor.
It's a benign, clinically benign tumor arising from the parotid gland.
Clinically benign tumor arising from the parotid gland. 80% of the benign tumors are pleomorphic. 80% tumors arise from parotid. Most of them are benign. Clear?
Yes.
Yes, and if you understood this part, and it will be a benign parotid swelling, and you'll find out what's the commonest etiology. Pleomorphic, you know, that's what you said. Don't jump to that. How do you explain these lymph nodes?
So they can be due to inflammation. So
Yeah,
other reasons
where?
not related to the carotid swelling.
They may not be related to
Because
parotid.
according to her age and
Upper respiratory
upper
tract
respiratory
infection.
tract infection.
Therefore, oral cavity examination would help. There is an element of pharyngitis. I had seen it in the previous case. So you will get unnecessarily dragged into, it can be tuberculosis also. Can there be tuberculosis of parotid as well as this? Yes. It's there's my own publication in Tropical Doctor Parotid Tuberculosis, if you look for it. 5 cases we reported. It can happen, but that's not your diagnosis. Your diagnosis is benign parotid swelling, probably pleomorphic. Why is it benign? Long duration.
Long duration.
Young patient. In points in history, always describe it like that. Points in history, points in examination. Points in history, longish history.
Long duration. Long tender.
Swelling has gradually increased in size. What would be the evidence, what features of malignant change in the swelling?
Fixity of the skin.
No. Sudden increase in size,
Sudden painful. Pain.
painless becoming painful, facial nerve involvement, getting mobile swelling getting fixed. These are the features. None are there. It's a benign swelling. How do you confirm your diagnosis? Finding expression cytology. Again, answer the same way as we discussed. I'll do investigations to confirm my diagnosis. But I asked you how you confirm it, then it's okay. And I'll do investigations to support my diagnosis, and then I'll do investigations to treat the patient. To confirm my diagnosis, I'll do finding expression cytology. It should be more or less confirmatory. Why not do a true cut biopsy? It will give you a tissue diagnosis. It leads to parotid fistula. It can lead to damage to the facial nerve, which is a very important problem. What's the minimum biopsy in parotid should be? What's the minimum biopsy in parotid tumors? If you want to do biopsy in parotid gland, what can you do? Superficial parotid. What's the minimum biopsy in thyroid? Any thyroid. You don't do true cut biopsy in thyroid also. It causes hemorrhage. It can cause recurrent unrelenting lung injury. Here it can cause parotid fistula, facial lung injury. Clear? Treatment.
Superficial parotidectomy. Because it
So what do you
generally
do? The facial-venous plane of any questions pertaining to parotid?
Fears about upgrading the tumor for potential tumor with the FNC are unfounded. Is that the
Sorry? Sorry, sir.
fears of upgrading a parotid tumor?
Or the needle track seedling. Needle track seedling, which means downgrading the tumor. No, it's the fears are ill-founded. Now FNAC is the recommended treatment, investigation. The reasons for it, particularly in our part of the world. Tuberculosis can be found, and you could treat her by antibiotics. There could be a suspicion of lymphoma. You You could treat it by drugs. There could be a suspicion of so many inflammatory conditions. But I'm not trying to say that there is zero risk. But it's considered now non-specific. We don't bother too much about it. FNAC is the investigational choice. Some people like to do an ultrasound before they do an FNAC. If the deep lobe is involved, what are they going to do? You'll first of all find it out clinically. Not by palpation, first by inspection. Remember, I'm repeating that. Because you end up doing bimanual palpation for swellings unnecessary. That's not required. It's not a routine. So when you do bimanual palpation, it's only when the tonsillar pillar is deviated. Clear?
Yes.
If it is a deep lobe involvement, you need a CT scan. Those are indications for requiring CT in a patient with prostate swelling, not otherwise. Extent, you're confused about the extent. You're confused about the involvement of the base of skull. You're confused about the deep lobe involvement. Then only need a CT. Okay?
Operability, we need cities.
That is what I mean.
Yes.
This is called operability in one word. Yeah. Thank you.
Can we give the course of antibiotics?
Let him ask this question. It's a very good question he's asked.
Can we give the course of antibiotics for 6 weeks for the lymph nodes? 6 weeks, sorry.
Antibiotics to make sure that they're not inflammatory. I think we'll do that. This is what is required to take care, to find out whether it's inflammatory or not. But suppose they don't disappear, does it become malignant? It's too simple a situation to be addressed, too difficult a situation to be addressed by a simple answer. FNAC from the carotid gland should be a guide. Then we'll do superficial paroticectomy. That will be our guide further. If you're in an ideal set of frozen section to follow. That's it. Any more questions?
Do we have to say superficial paroticectomy with preservation of the semen?
No, that is what superficial paroticectomy is. We're not discussing surgery, otherwise I would have told you. There can be superficial paroticectomy, total conservative paroticectomy, total radical paroticectomy. Radical means when you sacrifice the facial line, otherwise they both remain the same. Along with that, you may have to do neck dissections.